Hello students, this is Dr. Harshit Jain explaining the radiology for anatomy first prof. स्टूडेंट्स ये मैं बहुत ही मिनिमम बेसिक रेडियोलॉजी बता रहा हूँ. पास होने के लिए इतना तो कम से कम आना ही चाहिए. सो दिस इज द एक्सरे ऑफ स्कल lateral view. This is the lateral view. So in the X-ray skull, we generally ask the students to show us the paranasal sinuses. So this is the frontal sinus, this is the sphenoidal air sinus, this is maxillary sinus. The second thing we ask is the position of the sella turcica. You can see this is the sella turcica, and the sella turcica, in front of the sella turcica we have anterior clinoid process and behind it posterior clinoid process. Then we generally ask the students to show us the mastoid air cells. This is the mastoid air cells. Then we can also ask the students to show us the orbital plate. This is the orbital plate. Then the maxilla, hard palate, maxilla hard palate of the maxilla. You can see that this is the condylar process of mandible. Condylar process of mandible. Okay, condylar process of mandible. Then this is C1, this is C1. You can see the two tables, outer and inner table, and in between them this is diploid. And here we can see the coronoid suture. This is the coronoid suture, and this is the lambdoid suture. Okay, this is the lambdoid suture, and external occipital protuberance can also be seen. External occipital protuberance. Okay, so this is the anteroposterior view. This is the anteroposterior view. We can clearly see the frontal sinuses. We can see the nasal septum. We can see the nasal septum and the frontal sinuses. This is the frontal sinuses. This is the nasal septum. This is also the anteroposterior view. We can see the frontal sinus. This is the frontal sinus. These are the ethmoidal sinuses. These are the ethmoidal sinuses. We can see the maxillary sinuses. Maxillary sinuses. We can see the ramus of the mandible. Ramus of the mandible, and the angle of the mandible. This is the angle of the mandible. Okay, but the most important thing in anteroposterior view is ethmoidal sinuses, frontal sinuses. This is X-ray of abdomen region and the pelvic region. We can see the L5, L4, L3, L2, L1. Okay, and this is the sacrum. We can see the sacroiliac joint. We can see the sacroiliac joint, ilium bone. We can see here this is the shadow of the liver. This is the kidney. This is the splenic flexure. This is the splenic flexure. And the psoas muscle can also be seen. See, this is the psoas shadow. This is the psoas shadow. This is the psoas shadow. Okay. In it, we can see the ribs. The last rib will be attached to T12. After then L1, L2, L3, L4, L5. Sacrum, sacroiliac joint, ilium bone, femoral head, then hip joint we can see, and at the tip we can see the coccyx, pubis, the two rami of the pubis. One is superior, one is inferior. So this is the pelvic region X-ray. These are all anterior-posterior views. So we can see the pubic symphysis, secondary cartilaginous joint, sacroiliac joint. We can see the obturator foramen, superior pubic ramus, inferior pubic ramus, then the femoral head, femoral neck, greater trochanter, lesser trochanter, intertrochanteric line. This is the intertrochanteric line, lesser trochanter, greater trochanter. This is the crest of the ilium. The crest is the highest point. The crest of the ilium, anterior superior iliac spine, anterior inferior iliac spine, and fovea or at the head of the femur can also be seen. Fovea, a pit, foveal pit can be seen. So moving on, this is the barium meal for esophagus. If the esophagus should be more or less cylindrical in nature, if any deformity takes place, we'll see that afterwards. It's a barium meal. This is the histosalpingograph. Histosalpingography is done to check the patency of the ovarian tubes. Here we can see the tubes are patent. So histosalpingography. This is the PA view of the chest X-ray. It is very important X-ray in daily clinic practices. We can see the shed of the trachea. We can see the clavicle bone. Then the aortic knuckle. This is the right border, right atrium, border of the right atrium, left atrium, left ventricle, and the very important thing is these costophrenic angles. These should be pointed. If they are obliterated, then it will be a case of pleural effusion, and if the shape of the heart changes, then it also the shape can be boot shaped or tube shaped heart. But if any deformity occurs in its borders, then it is a clinical deformity. Okay, so we can again see. Okay, we'll write it. Aortic knuckle. This is the left atrium, border of the left atrium, left ventricle. Costophrenic angle, fundic shadow. This is the clavicle bone. These are the pulmonary markings. Okay, this is the shadow of the trachea. It should be in the middle. Trachea of the shadow. This is the diaphragm, hemidiaphragm. Okay, these tear shapes are the spines of the vertebrae. These are the spines of the vertebrae. Okay. So moving on, this is the X-ray of the shoulder joint. This is the clavicle bone. Clavicle bone is attached to the acromion process of the scapula to form a plain synovial joint. Acromion process is continuous in the spinous process. This is the coracoid process of the scapula. This is the humerus. This is the lateral border of the scapula. This is the glenoid cavity forming the shoulder joint. So if we see this X-ray, we can see the lesser tubercle and greater tubercle. This is the greater tubercle. Lesser tubercle. This is the acromion process. This is the coracoid process. This is the glenoid cavity. This is the clavicle going on to attach with the acromion process. This is the elbow joint. We can see the elbow joint. This is the olecranon process. This is the head of the radius. This is the olecranon process of ulna fitting into the trochlea. This is the trochlea, this is the trochlea of the humerus, and this is the capitulum. This is the capitulum articulates with the head of the radius. This is the trochlea of the humerus bone. Trochlea of the humerus bone fits into the trochlear notch of the ulna. This is the radial tuberosity. This is the radial tuberosity. This is the radial tuberosity, and these are the epicondyles. This is the medial epicondyle, and this is the lateral epicondyle. So again we see the lateral epicondyle, the medial epicondyle, the head of the radius, olecranon process, radial tuberosity. Okay, so again we move on to the in the X-ray of the hand, we generally ask about the carpals. We ask about the carpals. This is the radius, this is ulna, this is the styloid process of ulna, this is the styloid process of radius. So the mnemonic for learning the carpals is the "she looks too pretty, try to catch her." So this is scaphoid, this is lunate, this is triquetrum, and this is pisiform bone. Then we have hamate, this is capitate, this is trapezoid, and this is trapezium. So scaphoid, lunate, pisiform, triquetrum, hamate, scaphoid, capitate. Scaphoid we have already written in the first row. This is capitate, then trapezoid, then trapezium. Trapezium is the lateral most. Trapezium is the lateral most. Scaphoid is also the lateral most in the first row. This is the dinner fork deformity due to the fracture of the radius. This is the fracture of the radius, and dinner fork deformity due to the fracture of the radius, distal part of the radius, distal part of the radius. We can see the lesser trochanter, greater trochanter, and intertrochanteric crest. Fovea, this is the acetabulum, this is obturator foramen, this is the superior pubic ramus, this is the inferior pubic ramus. So the yellow dotted line is the Shenton's line. It is formed by the inferior border of the superior pubic ramus and the medial border of the femoral neck. If this line is not continuous, then there is deformity, as for example dysplasia. So we can see the lesser trochanter, the greater trochanter, intertrochanteric crest, femoral neck. This is the femoral neck. Fovea, okay. So this is the knee joint. You can see the shadow of patella. This is the intercondylar eminence. This is the fibula. Okay, this is tibia, this is femur above. Okay, lateral epicondyle, medial epicondyles. Okay, this is the foot X-ray. So these are the tarsals. Tarsal should be this, talus should be, you should be able to demarcate talus. In front of the talus we have the navicular. In front of the navicular we have three cuneiforms, medial, lateral, intermediate. To the lateral side of the navicular we have the cuboid bone, which articulates with the calcaneum. Okay, which articulates with the calcaneum. So some of the deformities, this is the example of achalasia cardia, in which a beak shaped appearance of esophagus appears. This is the example of diffuse esophageal spasm, which shows the typical corkscrew appearance. This is the example of pleural effusion. See this on this side, the costophrenic angle is not obliterated, while here there is no costophrenic angle, and hence is the example of pleural effusion. Here you can see the fracture of the clavicle. The medial end is displaced superiorly due to the pull by the sternocleidomastoid, while the lateral part is displaced inferiorly due to the pull by the shoulder joint. Here we can see the fracture in the scaphoid. This is scaphoid, this is lunate, pisiform, triquetrum, hamate, capitate, trapezoid and trapezium. Okay, here there is a fracture in the scaphoid. Okay, there is a fracture of scaphoid. So this is the broken Shenton's line. Here this side it is continuous, but here this is discontinuous due to the dysplasia. This is dysplasia. And in the last slide we can see there is the fracture in the talus bone. This is calcaneum, this is calcaneum, this is navicular. Okay, but you can see here the fracture in the talus bone. Okay, this is the tibia. Okay, so this is the very minimum basic for your first prof. Thank you.